Brilliant. So thank you very much for coming in today. I've just got a few minutes to start off with to talk a little bit about why it is important to know about cancer genetics in the community and why it matters. So next slide, please. So I think the first thing to say is that cancer is really just a disease of genetic change. So the only thing that differs between a normal cell and a cancer cell is the fact that that normal cell has acquired a variety of different mutations that occur in it to turn it into a cancer cell and give it a growth advantage and allow it to avoid cell suicide. So ideally, because cancer is really just a disease of genetic change, if we can actually read those genetic changes for every cancer, we get a lot closer to understanding why a cancer behaves the way it does, and of course, what the most appropriate treatment is going to be. And we should always keep in mind that when it comes to people with cancer, we have two different sets of genetic information to read. There's the information that you're born with and you inherit from your parents that we call germline testing. And then there's the ones that are unique to the tumor itself. Next slide, please. And in terms of why this is important in primary care, I think it's really important to understand that this is something that is becoming really common in primary care. I get lots and lots of contacts every day from GP practices who've had patients, for example, turn up who've had direct consumer testing, or they've bought a 23andMe kit from Superdrug and they turn up thinking that they have a wide range of genetic alterations. We have population testing going on at the moment. So we launched the Jewish BRCA program last year, where any patient with any individual in the country unaffected by cancer who has Jewish ancestry is able to sign up online and get a saliva kit for BRCA gene testing. And of course, we have ones that have been instigated in primary care, such as the Gallery trial, where patients had circulating tumor DNA offered to them as part of a nationwide trial. Next slide, please. And I think it's important to understand that all testing is not the same. So this, for example, is a referral that I actually received from a breast surgeon. And he had seen a lady in clinic. She had paid for an ancestry.com test, which you can get for about £150 online. These are not set up in order to report off cancer genetic genes or anything other than what percentage of Neanderthal you might be and where your family originated from. But people can now pay third-party programs to reanalyze the data that comes from things like ancestry.com and give them a list of potential mutations that may have been identified. Now, the problem with this lady is that she had turned up to see a breast cancer surgeon in the NHS, showing him a report that suggested that she had 2 BRCA1 mutations. And as a result of that report, he was arranging to undertake bilateral risk-reducing mastectomies in this lady unaffected by cancer. At some point, he realized that she hadn't ever seen anyone in genetics and referred her through to me. Now, this is hugely important because the results of this kind of testing are completely wrong in about 60% of cases. And indeed, this is one of those cases. It is impossible to inherit 2 BRCA1 mutations that are pathogenic. You don't survive to be born. That's lethal as a fetus. There's been no recorded evidence ever of someone being born who has 2 BRCA1 mutations. And anyone from a genetics lab who was trying to issue a report like that would have known it. But of course, there is no testing and there is no assessment of these kind of reports in the private sector. And therefore, this woman was about to have very extensive surgery for something that she doesn't have. Next slide, please. So in terms of the types of genomic testing that your patients may be receiving, the first one and the one that many people are sort of familiar with, having referred to clinical genetics for years, is the inherited, or what we call the germline testing. So these are tests for things that someone may have inherited from a parent, where we take a family history and identify there is a risk from that particular cancer gene being present in a family, and this is undertaken on blood. But increasingly, patients with cancer are also having large panels of tumour testing undertaken to help define the type of cancer they have, how aggressively it will behave, or which drug they are most appropriate for, and we call this somatic testing. Slightly confusingly, patients with cancer may also be having a ctDNA test. Now, ctDNA test is looking for fragments of tumour DNA, but we do it in the blood. So it's not uncommon for us to see patients who think they may have had germline testing because they've had a blood sample taken for a ctDNA test. But ctDNA is only looking for tumour-based mutations. It isn't looking specifically for inherited mutations. So this is something that increasingly is becoming a little bit more challenging for in the clinics for people to know who's had what testing. Next slide, please. So if we look at inherited cancers, on average, about 1 in 6 people who have cancer will have an inherited cause for this, but this varies hugely depending on the type of cancer that we see. So for example, patients like with lung cancer or melanoma very, very rarely have inherited causes for this, whereas patients with some of the endocrine tumours and thyroid cancers can have up to a 50% chance of an underlying gene alteration to have caused it. And when we look at things like common cancers, about 3 to 5% of breast cancer patients will have an underlying gene alteration. We've got about 1 in 5 of ovarian cancer patients, depending on the type of ovarian cancer, and about 5% of bowel cancer patients, rising up to about 10% if they're under the age of 50. So you can see that for most of the common cancers, thankfully, the risk of it being inherited is relatively small, but most of the rarer cancers have a much higher genetic proportion. Next slide, please. And of course, increasingly, this is important because of the treatment implications. And I'm sure you're going to hear a lot more about this with our further speakers. If you could just click through, please, Sandra. Perfect. So increasingly, the reason that we're doing large panels of gene tests on all of these patients is because increasingly this is telling us which drugs we should be giving patients. So for example, do they have a targetable mutation such as EGFR or BRAF, where we can give them a tablet that targets this specifically? Are they someone who should avoid things like radiation if they have something like a TP53 inherited mutation, which makes them extremely sensitive to radiation and gives them a high risk of a second cancer? Are they someone who could get onto a clinical trial with a novel drug? And increasingly, this is of huge interest in patients across the country who are exhausting their standard treatment options, where there are trials being set up to get early access to molecularly matched drugs. And of course, we've had for a while now antibody therapy. So for example, patients with HER2 mutations being able to get drugs like Herceptin or trastuzumab as part of their breast cancer management. Next slide, please. So just very quickly to talk a little bit about ctDNA, because this is something that is hugely increasing in terms of its use. And one of the biggest requests I get from GPs is from patients turning up asking if they can have one of these blood tests to tell whether or not they have cancer. So ctDNA, as I said, is looking in the blood for tiny fragments that may have come from tumour. So this is absolutely looking for a needle in a haystack. And it works really well for some types of cancers like lung or bowel cancer. And it works particularly well for cancers that are more advanced, which are shedding larger amounts of tumour. And if the cancer are in particular sites, so places like the liver and often the lungs are often really good at shedding DNA. It's really rubbish for some other types of cancers though. So if you have something like ovarian cancer or a brain tumour, it's much, much harder to pick these up in the blood because of things like the blood-brain barrier, and tumours that are sort of confined to one area of the body are much less likely to shed DNA. So these don't work for all tumours. But increasingly, we're using them to try and pick up cancer early or get to a diagnosis. And we have a pilot going on across the country at the moment where patients who turn up to a participating hospital in a respiratory clinic with suspected lung cancer can have a ctDNA test taken at the same time as the respiratory physician is requesting a bronchoscopy or a CT-guided biopsy. And in around a half to 3/4 of those patients, we will find measurable ctDNA in the blood, which allows us to make a diagnosis. And in many cases, if we find a mutation that is linked with a drug, such as EGFR, the patient can immediately start on treatment rather than having to wait for their bronchoscopy or their biopsy and the results. So as a result of this, we're finding that patients are taking on average half the time to get onto their treatment, which is obviously hugely important for patients who can go downhill very quickly. There are a number of other things that it's being looked at the moment. So these are things like early detection of recurrent disease, and also increasingly looking at patients who have had surgery and trying to decide who actually needs things like adjuvant chemotherapy to increase the chances of tumor response. So I think we'll be hearing a lot more about ctDNA in the coming years. Next slide, please.
Just a warning that we're slightly over time, so you've got about a minute probably to wrap up.
Yep,
Sorry.
I think we're just about done. So very briefly, just to talk about lung cancer, because that's what we're going to be focusing on for the rest of this. When I first trained in oncology, basically you had lung cancer, you got chemotherapy. It didn't really work for anyone. Everyone lived about the same length of time, but it was sometimes helpful for symptoms, and a few people benefited. But now, Sandra, if you'll just click through the animation for me, we have a whole host of targetable mutations which are linked with specific drugs. So we're now starting to see patients live really long lifetimes if we can get them onto the right drug. So this is about finding the switch that turned the cancer on and turning it off. And this is, yep, sorry, next one, Sandra. And this is an example of a patient who had a ctDNA test. We found an EGFR mutation and they were immediately able to get onto treatment. And to put it in context, this result came back and the patient was on treatment before they'd even had the date for their bronchoscopy. So this really is making things very different. I think if you just go to the final one, Sandra, it's my summary slide. So just to summarize, what you're seeing in primary care is only going to increase between the huge amount of direct consumer testing, the research programs, and of course the private testing. But just be aware that testing is of highly variable quality and reliability. Tumor testing is also increasing for all cancer patients. It's having a massive impact on things like treatment and prognosis and also rapid diagnosis. Thank you.